I think we'll get ready to start. So what you need to do is to put your mobile phones on silent mode, but have them ready because we're going to do some voting. And the voting is going to be done at the beginning before we start, and then at the end. And really the winner is the person who managed to persuade the most people to change their minds. So we might have to do some maths at the end to work that one out. I'll rely on you, James. But so let me welcome everybody to this wonderful meeting, including those online. I'm so delighted to be here. After many years of coming to these meetings, we're having it in Africa. So it's fantastic. The voting system we'll be looking at the QR code, which I'll put up in a minute. But just before we start, so this is a debate about statins and giving statins to young adults with perinatal HIV. And I'll read out the motion so you're very clear about who is pro and con in a moment. But just, can I have the next slide, please? So this is for the baby boomers in the room, of which I am one. I think there were 15% from yesterday afternoon when I counted up. So they're the ones that will know all about what it's like to be on a statin, me included. And of course, next slide, please. This is what they look like. But we're going to be talking about young adults who obviously have had risks for earlier in life. So back to the voting slide with the QR code, please. And here we have the motion. So the motion for this debate is that all young adults with perinatal HIV should receive a statin to reduce the risk of cardiovascular-related morbidity and mortality. So pro is blue and con is red. Can you put your QR code on? And I expect the baby boomers to be able to do this as well, even though they're a bit, they have a few problems. And start voting for what you believe. And then what we're going to do is to have two wonderful presentations from our African colleagues. First of all, Professor Musiime, and I think this is your first time at this meeting, isn't it? Yes, it is. So very welcome. And he is a professor in clinical medicine and also epidemiology at the University of Botswana. And then he is going to be pro the motion. And then con the motion is young Victor Musiime, associate professor at Makerere and also at JCRC, my former PhD student. So I'm non-biased. And he is going to be against the motion. So without further ado, you each have 10 minutes to persuade the audience of your motion. Would you like to start, Mr. Billy?
Let's see the vote.
Oh, sorry. Let's see the vote. Yeah, apologies. So pro is 37%, and a con is 63%. So I'm sorry to give you a heart attack as you stand up, but you have to persuade your audience. Thank you very much. Perfectly to time. You've got 11 seconds left, which, Victor, you're allowed to steal. So you are going to put forward the opposite view.
Thank you very much. I hope you can see me. Am I visible? I think I'm fine. Yeah, the question is easy. Should all young adults with prenatally acquired HIV receive a statin to reduce the risk of cardiovascular-related morbidity and mortality? And it's certainly not, because the audience actually got it very well at the beginning. And I just, my task now is to convince the 37% that is left that really there's no time for this. Now, let's start with what the evidence is with statins among young people living with HIV. There's very minimal data. There's a study that was done and published around 2017, recruited 28 participants that were aged 10 to 24 years. All these participants had a high LDL, okay? It was over 130 milligrams per deciliter. And then for these people, they used atorvastatin, and for these people, it showed that there was a reduction in the lipid levels. This was a safety and efficacy study in reduction of lipid levels, but not necessarily the cardiovascular events. So the retrieved participants, like Mosepele told you, were all over 40 years, very far from being young. And the cardiovascular disease risk, let's look at the cardiovascular risk, what has been observed over the years. So there was a study that was done in Nigeria that showed quite a bit of risk. And also, yesterday, you had my colleague Saera presented data from our cohort about what observations we've learned over the years from this cohort of children. We are seeing some changes, but very, very importantly, these changes really are associated with some bit of lipid increase in lipid levels, and also a bit of increase in the thickness of their carotids, which could probably suggest a risk of cardiovascular disease. But we also observed that this was related to lots of environmental and lifestyle risk factors, things like ambient air pollution and other things related to their morbidity. But very, very importantly, we noted that when you start ART early and you keep it prolonged, you reduce the progression of whatever observations you see at the beginning. So another study was done, the same exact population that Mosepele's study enrolled. These were adults living with HIV, over 40 years of age, and they were compared, 155 of them were compared with those without HIV. They were followed up for over 4 years. The median was 4 years. They had been on ART for over 3 years. And they measured their markers of thickening of their carotids, what they call the carotid IMT. So they measured this annually. And at the end of the 4-year follow-up, there was no difference in the thickness of their carotids. Both those who received, or who were HIV infected, or who are living with HIV, who were taking the ART in a sustained way, and those without HIV. So being on ART prevented them from progressing. So the key message here, even if this could give you a risk like he was telling us, but if you take your ART and in a sustained way, there won't be any progression. So your risk does not increase as long as you're taking your ART and sustain it and remain suppressed. So what does an additional statin do? Now, this systematic review was done among young people living with HIV, 2013 of them. In this systematic review, it was seen that 1 in 4 of them did not adhere to their medication. And many of the factors that are associated with non-adherence, one was orphan status, because these were orphans. Being a double orphan increased your chances of non-adherence, but very, very importantly, increased pill burden. So when you add a statin, you're adding the number of pills. So that really affects the adherence. And remember, what these children needed, or what these young people needed, was to take their ART and take it well. Now you're adding pill burden to reduce the adherence. So what exactly are you doing? So now the second factor that is a problem is the cost. There's somebody very famous for issuing executive orders. And among the things he says, he uses very frightening words, freezing, immediately, things like that. So there is one that he issued that really was about freezing funding, and it has implications for all of us in this room. Now, national programs are required now to take up the burden. I mean, they were supposed to do this in the first place, but now that they have to do it, they have to understand the priorities. So amidst this funding crisis, where national programs have to pick up the bill, they have, when now they are getting used to the idea that, you know, we have to pay for drugs, to pay for lab tests, and you have to pay for supply chain and other things, then you tell them, you know what, there's this new drug you need to add on. It reduces the risk only slightly, and you see, just buy it. But also, as you buy the drug, add glucose monitoring, because statins could increase chances of getting diabetes, and also lipid monitoring. I give you all your best wishes. I approach your minister, and hopefully they will listen to you, but certainly they will not. And, and that means when you roll out this statin within the programs, the people that are likely to pick up this cost are the young people living with HIV and their families. And this is a big cost. So please don't burden the young people living with HIV. They will manage their drugs very well. They will swallow them. If you give them this extra burden, you're also increasing stress. Stress increases cardiovascular risk. So, ladies and gentlemen, don't even think about it. Now, let's look at Reprieve in context. Now, Reprieve, when you look at the results of Reprieve, for 100 people needed to be treated for 5 years to avoid one major cardiovascular event. 5 years, 100 people. But looking at it closely, if you looked at only those with extra risk, there's a risk of over 10, that number reduces to 34. And the Reprieve cohort, or it was a large cohort, but in Sub-Saharan Africa, including in Botswana, where Mo comes from, all over the continent, there were 1,157 participants, which is great. But only 8 events were observed in that cohort. Among the 8, 5 were in placebo and 3 were in the statin group. So you can see these events in people who are over, who probably had a lot of other risk factors going on. Okay? So the participants, as I mentioned earlier, were over 40 years. Less than a third were women. And we saw from yesterday, like what Sayera said and others, that the females have a slightly increased risk. But there is a very small proportion of the ladies. And also less than half were in low and middle income countries where majority of the patients live. So the important thing that we could learn from this, if we were to get some action, this was a large trial, what could we do? There could be a role for a statin in those at risk. If you identify the people at risk, that could be a role. And what are some of the things that could be done? Now, the things that could be done, one is integration of care, lifestyle modification, adherence to ART, mental health, and lots of other things that could be done. This is doable, and we should do it, okay? Then, what do the guidelines say? Now, Mo talked about it. Talked about the British guidelines. These are the American guidelines. Very importantly, in these people who are at low risk, for the group less than 40 years, for those above 40 years, they say, well, you can give a statin, which is fine. But those less than 40, just look at this, and I quote. Now, they say that data is insufficient for a guidance against or for a statin. And they say that, like in the general population, there should be some lifestyle modification, and probably that is what could work. And I certainly agree with them. Now, so in summary, we have very limited data for use of statins among young people living with HIV. The statins, when given universally, are not cost-effective, and this is a very big problem given the funding landscape. The statins could have a slight role in those with a very high risk of cardiovascular disease. So, ladies and gentlemen, with the funds we have, we could use them better and avert this relatively small number of events by promoting lifestyle modification, integrated NCD care, enhanced treatment adherence, and optimizing comprehensive HIV care. Thank you very much.
Thank you, Victor. So now, audience, is time for discussion. So questions to our two debaters, please. Don't be shy. You haven't been so far. Okay, we've got Roger.
Is there any, can anyone summarize the actual data in young adults for excess cardiovascular mortality? I haven't heard like a summary of the clinical data for 30 to 40-year-olds. Is that summarizable?
So would either of our contestants like to summarize? We might ask others who are involved in long-term follow-up of perinatal kids, but the cardiovascular risks that they have when they get to 30 or 40. We are aware of the fact that actually follow-up of perinatal HIV kids needs more work, and we may not have those data very well.
Yeah, maybe Roger, what I could say is that the observations, the data that is out there is showing that there is a tendency to atherosclerosis, but with ART, there is no disease progression. Now, about the major events themselves, there is very little data that is published out there, and maybe there are no standard cohorts that have done this, but really, my guess is that there are not very many of the major events.
Yeah, I'm not aware of any large data that has described that, especially in the African context. I mean, the same will apply to adults, really. Even in adults living with HIV in Africa, we don't have the likes of Framingham, the likes of Reprieve. As he said, very few are enrolled in Africa.
So we have to rely on things like whether carotid IMT is going to be a surrogate for cardiac events. Please.
I just want to follow up what Victor said in terms of data. So there's data highlighting subclinical vascular disease using IMT and endothelial dysfunction up to 20 to 25 years of age. In terms of heart outcomes and MI, there was a study out of Mass General from Virginia Triant looking at incidence of MI, and there was about 1.5 increased risk of MI in those 18 to 30-year-olds, but she didn't look at modes of transmission, so whether those were horizontally acquired or perinatally acquired. Those are really the only data that we have for heart outcome. The rest is really surrogate markers of cardiovascular disease. Okay,
another question over here. Do you want to, I don't think we'll come back on that. Thank you for that information.
I just wanted to, so we have, so heart outcomes. So Amara is your mama from Michigan State University. We have been looking at the children with perinatally acquired HIV just observationally, and I have to second the idea that long-term outcomes, cardiovascular, heart endpoint is kind of hard. But one thing we've been looking at, and I asked that question to someone, and it's motivated by the concern for excess cardiovascular risk in this population, was to even study things like dyslipidemia, LDL, HDL, and associated them with adverse morbidity outcomes. And we can see in our cohort that HDL is generally lower in children that are living with HIV. But then when you look at LDL, which is really not that different from the other three groups, at least in our observational context, we are not seeing necessarily consistent associations with morbidity. And I did wonder, lead to my question about whether some of the, it's not CIMT, it's not some of the more refined ways to think about cardiovascular risk, but are some of the ways we look at these biomarkers that are easier to measure, LDL, HDL. Is it different, or is it the same in children when you're looking at it relative to morbidity, or should we be thinking about that a little bit more?
So what's your specific question to our two debaters, or are you adding to the
No, I was actually adding to
information?
the discussion about what the evidence for higher cardiovascular risk in children living with HIV, and whether we see those outcomes.
So mainly it's surrogates that we're talking about,
It has
which
to be, yeah.
which it has to be. So bearing that in mind, any more questions for our two debaters? In order to clarify how you're going to re-vote. At the back there? Did you have a question there? No, you've had it answered. Rashida, I think you had your hand up.
Can I ask the debaters regarding the data, how much of this data is coming from cohorts in Africa versus cohorts in the US and the UK and the global north? Because the risk profile will contextually vary in a big way. The obesity epidemic, I mean, whilst there is one happening in the global south as well, it's different. Lipid profiles will be different, etc. So I think that needs to be taken into account, how much of that data is being driven by what's happening in the global north. The second question is, are the levels, do you have normative ranges for example, blood pressure, etc., for children and adolescents in the global south? We can't extrapolate those that are from adults, but also those from the global north. So how much of that has been taken into account with the data coming from that, which will help interpret all of this? Over. Thank you.
Okay, Victor, do you want to go first on that one?
Oh, yeah, I will. So Rashida, a very direct answer. I'll give you one, the reprieve, as I told you earlier, had only less than 20% from Africa, for example, very small proportion, less than 15%. But the cohort that I gave from Uganda, the one that was done not far from here, in southwestern Uganda, it recruited 300 participants, 310, and it had both those living with the HIV and those without HIV, and compared. So that means there was a picture of what was happening in the general population. After the people, at the beginning, they saw that there was a slight difference in the carotid IMT, because that was at the beginning. But over time, when they progressed and these people were on ART, there was no difference whatsoever over follow-up between what was in the general population, that's those without HIV, and those with HIV that were stable on ART. So definitely, what that shows us that somebody on ART, the HIV does not increase their risk different from the general population.
So that was quite a small study, wasn't it?
Yeah.
And here's Victor talking about adults. So maybe, Mr. Pili, you could talk about children. Because, of course, there are some studies looking at carotid markers.
Even when it looks at carotid IMT, over time, as long as someone is on ART, and so our cohort that we have, we had a very long cohort, followed them up for about 10 years. Once they are stable on their ART, there is no increase in their risk. That's the key marker. Stable on their ART, no increase in risk.
Okay, Mr. Billy.
I would say, I've done those studies also looking at CIMT. It is not a very sensitive marker of atherosclerotic disease. The best marker is PET CT, which has really proven that HIV is associated with vascular inflammation. I think a lot of those studies were done out of MGH and UCSF. So I think some kind of mechanics study along those lines would be very helpful. And I think Reprieve has a sub-study in which they were looking at PET CTs also.
Thank you. Sarah.
Yes, I just want to extend the discussion beyond cardiovascular disease. And maybe you'd like to comment, maybe Victor, on the potential for reducing in some way cancer risk. There's a lot of interest, obviously, in statins having a much broader, benefit than cardiovascular disease. So.
Okay, well, Mr. Pili, do you want to start with that one?
I'm not aware of data around reduction of cancer risk with a statin therapy, but what I presented earlier was, I think you saw in the reprieve intervention arm that there was a slowing down in the pace of aging, and by extension, you may expect other aging-related diseases to potentially be reduced by that.
Victor, any comments on that?
In a way, just like sustained ART could do. Sustained ART, well given, can slow aging. And in many ways, sustained ART with all the lifestyle modifications and everything else, integrated care, can also slow down your risk of aging and getting cancer-related diseases. So I'm not aware of any other data, but by extension, it may not be due to statins themselves, but lots of other things.
Okay.
By extension.
I think we're out of time for questions. Is that correct? Yeah, we're out of time. When it's gone pink. Yeah, good. 1 minute to sum up before we re-vote. So get your phones ready to re-vote. And Mr. Pelly, over to you.
Thank you very much. I think this is a game changer. I realize the conversation still circled around traditional risk factors. I think what my friend Victor projected, the first few slides, were looking at traditional risk factors. And what I said was, in the reprieve trial and the associated mechanistic studies, the reduction was independent of those traditional risk factors, and that there is a new mechanism by which pitivastatin works. In HIV-infected people living with HIV only, it induces PCOLC, and PCOLC is associated with the regression of plaque. So I think we need to think the way we are approaching this is no longer traditional risk. I think Victor talked about extra pill. Technology allows for there to be fixed dose combinations, so it can be added and combined potentially with ARVs. He talked about monitoring post, what the monitoring that was done in reprieve. That was a trial. In routine care, people on atorvastatin don't get screened as much as it was done in reprieve. And then he also talked about a small percentage of people being from Africa. And that trial, almost a little over 40% were actually black, so representing similar racial mix. And that there is no evidence that exercise, reducing environmental pollution will induce PCOLC, which will cause regression of plaque. And then finally, the guidelines that he quoted where he said there was no evidence, they predated, they were from 2024. Some of this data around PCOLC came out this year. So indeed, they did not have that data. Now we have it.
Very good. Excellent. So, Victor, step up.
Okay. Now, ladies and gentlemen, can you make history and vote overwhelmingly, 100%? This will be the first time when you all vote 104% against the statins. These are reasons why. One, they're not cost effective. We have all seen that this is an extra cost, an extra pill, extra so many things that statins will come with statins. So they are not practical in this present time. Secondly, when you have sustained ART, you reduce the risk. That's very, very important. And we don't want other things that could affect sustained ART. This can be done very well with integrated care. That's the model that we need to do. Let's identify those at risk and give them the statin. And how do you identify those at risk? With differentiated service delivery models, you can easily get these people. Put them on the pill so that you reduce their risk, the ones that really will be likely to get it. So, ladies and gentlemen, vote overwhelmingly against the statins. Thank you very much.
Okay, thank you. A round of applause before we vote. And then get your phones ready to vote. This is much easier than counting hands in a room where you can't see them. Vote again. Just to remind you of the motion, all young adults with perinatal HIV should receive a statin to reduce the risk of cardiovascular-related morbidity and mortality. Well, you're quite good at voting quickly. Got to 71. Oh. Okay, I think we've just about got there. Oh no, a few more.
All votes count, die.
What we can say, or I can say, is that, what we can say is Victor's not going to get his 100% first time ever.
Just wait and see. Wow. Okay.
Okay. So, despite an excellent sum up, and a very, maybe the word all at the beginning of young adults was what persuaded you all to think about the words in the motion. But thank you both very much for a very interesting debate, very informative, very entertaining. And Victor, you'll do better next time.